Okay, everybody, welcome. So, this is a regular part of our life here now at Deerfield, and we're so incredibly grateful. Some of you get to enjoy Will and Tasha in your own like little private cone of secrecy. But we get to, those of us who don't benefit from their direct care, do have the advantage of learning from them about 3 or 4 times a year. The foundation sponsors MAHEC's Center for Healthy Aging, and we're really, really proud to be partnering and supportive of the work that Will and Tasha and others do in Western North Carolina for older adults. And in addition, they do a lot of education for caregivers, medical providers across the country who need to know more about caring for older adults. These two, how lucky are we? We're so incredibly lucky. So, on behalf of the foundation and Deerfield, thank you for being here. They're going to talk about diabetes. A couple notes. We are recording this so that you can let the peeps know who are not here, who should be, that they can go to My Deerfield probably later this week, and it will be uploaded to both the health care space and also on the philanthropy page where we talk about our partnerships. And then I have to be in 2 places at once, so I'm not going to be here. But Faith Ann Bishke, who is my colleague and partner in this work, is in the booth, and she's going to be here after, so she will facilitate questions. And then the last thing, Will and Tasha, you don't know this, but we have a guest speaker, and that's Jim Havard. And so at the very end, I think Jim's going to talk a little bit about the diabetes subgroup of the health care committee, health and wellness committee. Okay, Will and Tasha, welcome.
Hey everyone, it's Will Mclean. It's so good to see. I think I know most of you guys, but just in case, Will Mclean from MAHEC and also your medical director. As much as much of a kind welcome as Michelle gave us, we are equally thankful that to be here with you guys and to be part of this community. It truly is special. They'll never stop inspiring us, and we can't thank Michelle and Deerfield, as well as you guys, for all of your support. You truly make our work possible in addition to inspiring us day in and day out. I took the first lead, letting my better half go afterwards. But we're going to tackle diabetes, which truthfully is a huge topic. Tasha was joking that often this topic can take up weeks of courses. And so we're just going to give a couple of high-level tidbits, but also trying to dive in knowing that many of you guys have dealt with diabetes personally or with family members, and so hopefully appease both those that are interested in general knowledge and also folks that may have one or more granular interest. Good. All right. Without further ado, I'll jump in and we'll get started. So I think most of you guys probably have some sense about what diabetes is. Diabetes, in its essence, is a disease that causes your blood sugar, the sugar that's in your blood vessels, to be too high at any given time. And that can be for a variety of different reasons. The most common 2 reasons we think of are if you don't have enough, if you don't produce enough insulin, which tells your body to take up your muscles and other sorted body tissues to take blood sugar out of your blood vessels. Or in the case of, which is the case of type 1 diabetes, or in the case of type 2 diabetes, which is the more common type of diabetes, and the diabetes that we'll really focus on today, it's a problem where our body doesn't recognize the insulin that we do have and doesn't take up enough blood sugar because of that. How common is diabetes? It's remarkably common. We think about around 30 million Americans at any given time having diabetes, and the majority of those are the older adults, adults over the age of 65, are vastly overrepresented in that group, to the point where about 1 in 5 older adults have some form of diabetes. Again, most of that is type 2 diabetes. And even higher the levels of undiagnosed diabetes. So we think about 27% of folks over the age of 65 may have diabetes, diagnosed or undiagnosed. I think it is of note, just to touch on quickly, there is a lot of times in diabetes when you get this question of what is pre-diabetes? Okay, I get diabetes. What about pre-diabetes? And pre-diabetes is this entity that we think of that if we are typically make our diagnosis of diabetes based on a factor called the A1C, which is, we'll talk a little bit more about it in a second, but it's your average blood sugar over the past 3 months. We have this test that tells us the average blood sugar over the past 3 months. Prediabetes is a scale that says that if your A1C, that average blood sugar over the past 3 months, is between X and Y. I won't go too deep into details of exactly when that's diagnosed, but if it's in that level before it becomes official diabetes, but but over normal A1C, we've sort of started calling people in this level pre-diabetics, and we're actually starting to think, is this truly a good idea? As you can see, here's a study that was done that shows folks. Let's see if you can see that little red dot up here in this yellow are folks in that pre-diabetic category. And down here in the green are folks that have a normal blood sugar level. And when a cohort of people in both of these levels were followed over 6.5 years, which is a fairly long time, we find that only a small portion of those with prediabetes actually go on to become diabetic. The vast majority of folks in that pre-diabetic level, even after 6.5 years, are actually still in that sort of pre-diabetic, that sort of no man's land, if you will. And actually, a greater percentage of folks that start off that 6.5 years have gone on to develop diabetes. So all to say that even though these folks in this pre-diabetic level may not have quote-unquote normal blood sugars, it's still unclear exactly how important that is, how dangerous that is. And I should say, too, that at least at that 6.5 year time level, there was no increased risk of death from being pre-diabetic as opposed to, say, somebody with brain diabetes. So we're still more to come. But all to say that if you've been assigned this name of pre-diabetes, it's not to say don't worry. It's not to say that, as we'll talk about later, not to think about some really helpful, important lifestyle changes. But it's also not it's far from being sentenced to diabetes or early death. We're still trying to figure out exactly what that means. So one of the problems with diabetes is that, yes, you can have high blood sugars, but it's not necessarily just the blood sugars that cause trouble. It's the long-term consequences of the sugars in our bodies. And we know that sugars, by their chemistry, can have a really destructive effect on some of our body's tissues. And then over the course of years of having diabetes, it puts us at higher risk of heart disease, puts us at higher risk of kidney disease, of having issues with our eyes, specifically our retinas. And it also seems to confer an increased risk of that sort of nebulous term that we call frailty. Uh, but we also know that for folks specifically over the age of 65, conversely, they also have a much higher risk of complications from low blood sugars. So those 75 and older have twice as many ER visits from low sugars compared to the general diabetic population. So it's no doubt that diabetes puts older adults in this rock and a hard place where we're worried about long-term risks. We're also worried about more immediate risks of low blood sugars, which is a balance that Tasha will talk about in a minute. And additionally, we know that low blood sugar, as we age, looks and feels differently. So some of the same signs that younger adults suffer from when they have low blood sugar can be a lot more nebulous and confusing in folks with older adults. I wanted to come back to this idea of A1C just to dig a little bit deeper. Like I said before, it's this idea that um, uh, we have this test that can look back at the last 3 months and get some sense of your average blood sugar. But to bring it into the point I was just making about low blood sugars, we know that the higher your A1C, the actually the threshold for feeling a low blood sugar actually increases. So if you've got poorly controlled diabetes, the the, the level at which your body starts feeling relative low blood sugar will be higher, which can also make it confusing. And just for your for general information, uh, those diabetic goals excuse me, those diabetic diagnostic criteria for A1C. If you're really above 6.5, that's your diabetic level. Just for all right, I'll turn over to Tasha to talk a little bit more about that goal and this new paradigm that we're dealing with the fact that we know that long-term high sugars can cause a lot of trouble, but conversely, that low blood sugars can be just as harmful.
Yeah. So this is one of those times where we have to recalibrate. And some people don't get diagnosed with diabetes for the first time until they're older. Others of you in the room who have diabetes maybe have been living with it for a long time. And then we have to start thinking about it differently because probably you've spent most of your time living with diabetes being told that your A1C, again, that 3-month average of your blood sugars, should be less than 7%. And now we have a trade off on our hands. So, those competing risks that Will has been alluding to, obviously, there are risks associated with running a higher blood sugar for a long period of time. And down the road, 10, 15 years past diagnosis, we start bumping into a higher risk of things like kidney problems and heart attacks and strokes. But keep in mind that there are also things happening in the moment associated with an acutely high or low blood sugar, and we're balancing those risks too. So it does get a lot more challenging. When we're thinking about some of those high blood sugars, um, if you've ever taken a diabetes class in the past, you might have been told about the polys. So polydipsia means a lot of excessive thirst. Polyuria means having to pee more often, and polyphagia means you're more hungry. So sometimes we think of those as your body cueing you up um, that your blood sugar might be high. Those symptoms look a little different potentially when you get older too, in addition to the ways that low blood sugars can look different. And so you might be running more into like urinary urgency or frequency, having to rush to the bathroom, just being generally dehydrated. It can lead to the higher risk of infections and falls and injuries, which unfortunately are a sign or a symptom of a low blood sugar too. Um, so we're having to balance these competing risks. And because we're balancing these things, it is not only acceptable but preferred in many instances that the goal that we target for you with your A1C, with the blood sugar that you're at when you go to bed at night, and the blood sugar that you wake up with in the morning, that those are higher. They're in a higher place than they were for younger folks. And part of the reason for that is these graphs, which may be a little difficult at the outset to interpret, but I'm going to help you. This association between A1C, which is plotted along the bottom of these graphs, and then mortality or death along the vertical. And so we see this kind of like J-shaped curve in both of these instances where you're at a greater risk of death. Yes, when your A1C is wildly uncontrolled or high, in this 9-10 range. But guess what? It's higher at a very low A1C as well. And that J-shaped curve is even more pronounced for people who are using medications that increase the risk for hypoglycemia or low blood sugar, insulin being chief among those. And we would factor other medications like glipizide or glyburide in with that as well. I'm going to talk more about the medications in a little bit. So when you come to see us, and we're trying to think for you, this one person sitting in front of us, what A1C goal makes the most sense and gives us something to target when we draw those labs every 3 or 6 months. We're thinking about lots of different factors. So if you're someone who was maybe just diagnosed with diabetes, and this is kind of small and hard to read, but it shows shorter diabetes duration, you're at pretty low risk for low blood sugars. You don't have any pre-existing heart disease. You don't really have a whole lot else going on. Generally speaking, you're pretty healthy. Then that might drive us down toward a lower A1C goal. We can probably achieve that safely. That's just fine. But then there are other factors, like if you've had diabetes for a really long time, or you're at higher risk for low blood sugars at baseline, or if you already have established cardiovascular disease or kidney disease, then we want to push that goal higher. And so this table actually comes to us from the American Diabetes Association, who puts out a really comprehensive set of guidelines every single year in January. And they've updated their entire section that is specific to older adults. I wish all clinical practice guidelines had an entire section just to help us figure out whether things should look different in people who are older. And they tell us that if you are healthy with few chronic conditions, no problems with memory or function, performing your activities of daily living, that an A1C goal less than 7.5% may be safely achievable. And again, that's as opposed to the less than 7% that we might shoot for in a 40-year-old person. The reality is that 70% of adults with type 2 diabetes have at least 2 other chronic conditions on top of their diabetes. So many, many, many people actually fit in this middle category where we're now running into multiple conditions. There might be some changes in functional abilities, maybe some mild cognitive impairment. It could be any of those things. It doesn't have to be all 3. That might drive us toward this higher goal of less than 8%. I'm not going to talk about these numbers over here right now, but they do give us guidance about how that might translate in terms of if you're someone who's checking your blood sugar, what we would want that to look like when you wake up and when you go to bed at night. And then for people who are maybe living in a nursing home or who have end-stage illness or more moderate or severe cognitive impairment or who are needing more help with just basic self-care tasks, that less than 8.5% is completely acceptable in that circumstance. Okay. Are there questions on that before I pass it off to Will? And then I'm going to come back and talk about medications after he talks about lifestyle things. Yes, please. Yeah, 5.7 to 6.4 would be the pre-diabetes range. The question was an A1C of 5.9. Yeah, that's a good question. Yeah, and I used to the question was kind of what are your odds then of progressing on to diabetes at that point? And I used to know those numbers for the general population, and I can't quote them offhand. I don't know if Will has them, but I think to his point earlier when we were looking at that sort of colorful graph that showed the way that older people in particular progress or don't progress to diabetes, that whatever that number is, it's going to be different for people 65 and older. And generally speaking, if you were diagnosed with prediabetes for the first time as an older person, then there is a chance, about a 1 in 10 chance within, 7 years of going on to develop diabetes. But there's actually a greater chance of either holding your own and remaining in that prediabetes stage or even regressing to a point where you have a normal blood sugar. Did I say those numbers right? Great. Yeah.
One study that we got the graph from, it was 9% progressed to pre-diabetics. 9%, about 1 out of 10, went on to become diabetic. Whereas, interestingly, 13% went from pre-diabetic to normal. So the number of folks becoming normal in that pre-diabetic category was actually higher than the folks that progressed to diabetes. I didn't put that point so artfully earlier, but hopefully that helps. So it's a great question. I and I should have said this to begin with because I think some of you have pointed out that when you look around at Deerfield, that 1 in 5 number of the folks over the age of 65 at Deerfield doesn't look quite the same. I don't think I can tell you that 1 in 5 people at Deerfield don't have diabetes. And so there are, I think, some of those same factors that affect the general risk of diabetes probably apply in that range of pre-diabetics as well. Things like socioeconomic status, the number of folks that have college degrees. I think the risk of developing diabetes is about twice as much if you don't have a college degree as if you do. And so some of these socioeconomic factors play a role. We don't typically think about type 2 diabetes having a single genetic factor, like some diseases, but sometimes there can be a variety of different genetic factors that can play a role. So some of those same things that put you at high risk of developing diabetes, period, also would suggest that those folks with pre-diabetes at 10% probably share some of those same risk factors.
These are interesting things to think about, right? Like when I got my college degree, there was nothing in my diploma that I received that protects me from diabetes, right? That would be great. But it's all an association, right? People who graduate from college tend to forward into the future have better access to health care and different health behaviors. Um, so it's something for us to be mindful of as we try to advance the health of all people. Yeah. Yeah. These numbers?
Yeah,
No.
well, because I'm a type 1, and I relevance.
Yeah, so it
Right,
actually
sure.
says specifically in the standards of
Right.
care that this is true regardless of the type of diabetes. So we need to be loosening up on those goals for type 1 and type 2. Yeah, that's the recommendation. Um, Thank you for sharing that. I do think that a lot of people with type 1 have lived with it on average a lot longer than people who have lived with type 2 and have probably spent many decades being very focused on maybe keeping an A1C of less than 7, maybe even less than 6.5%. But the experts that put together this guideline are very careful to point out that these goals in older people apply regardless of the underlying pathophysiology of the diabetes. So it feels like more of a paradigm shift for people with type 1 because you've just lived longer focusing on tighter goals. But the reasons that we relax these goals related to the risks for low blood sugars are the exact same. And perhaps there's an even finer point on it if you have type 1 diabetes. Okay, I will pass it off. We'll talk about lifestyle. I'll be back to talk about medication.
Awesome. So for you guys that came to the Heart Healthy Talk a couple weeks back, a lot of this will sound very, very familiar. That a lot of the recommendations that we have for folks with diabetes, vis-a-vis lifestyle changes, are very similar for some of the protective things that help with heart disease. Our sort of gold standard, and we can talk a little bit about different variations of this, but our gold standard guideline for diet with folks for diabetes really revolves around something that looks similar to the Mediterranean diet. So thinking about a lot of whole grain foods, a lot of lean, lean proteins with that could be meat or non-meat sources, um, nuts, seeds, lots of vegetables. Uh, we also think about if we can encourage 3 to 7% weight loss, that seems to also dramatically improve outcomes with folks with diabetes. And this little bullet point that got lost says really trying to focus on water intake, not so much other liquids that have calories in them or carbohydrates, including alcohol. Um, this is another version of what I've just said that really thinking about the American Heart Association, thinking about some of the overarching principles of good diet within diabetes, thinking about your plate being half fruits and veggies, a quarter whole grain, a quarter lean protein. What constitutes carbohydrates can be tricky for some folks, and there are a lot of misconceptions about where carbohydrates live. So I'm curious. Let's do a little test here. Cookies. Do they have carbs in them? Yes. How about dressing though? Yes, good. Pasta? Yeah, yeah. How about oranges? Yep. Now, how about banana? How about barbecue sauce? How about oatmeal? Yeah. And how about soup? Good. And how about bread and milk? All right, you guys, 100%. But I do think it's important that we make the that we make the that we make the case that not all carbohydrates are created equal. And so, really, we think about carbohydrates, and this is where this idea of that not all carbohydrates are bad. As you saw, American Heart Association says we should get a fourth of our plate should be whole grains, which grains usually are at least in part carbohydrate. So not all carbohydrates are created equally. That we really want to think about carbohydrates, about how quickly they're absorbed into our blood. And one of the key factors in how quickly carbohydrates are absorbed in our blood has to do with the amount of fiber that is consumed with the carbohydrate. So high fiber meals, high fiber foods that also include carbohydrates are going to end up raising your blood sugar less and do it in a much more slow manner. And it's something that's high carbohydrate, often highly processed, that's going to get absorbed more quickly into your bloodstream with lower fiber. So your cookies, your 1,000-hour ranch, your plain pasta, your barbecue sauce, are going to be absorbed into your body a lot differently than the fruits and vegetables, even admitting that they've got carbohydrates too. You can make radical differences in your average blood sugar through your diet. Right here, and what most of our American Diabetes Association, most of our governing bodies are not necessarily saying cut out carbs altogether, do it in a sustainable way. But there are some methods like a ketogenic diet. Is anybody familiar with ketogenic diet? Yeah. So there are some methods where you radically cut out carbohydrates altogether. And this does make a dramatic effect in your average blood sugar. If you're not taking any carbohydrates, then your body's blood sugar is not gonna raise. And that seems to, in some instances, completely reduce the chance of you can almost, in a sense, reverse your risk of diabetes. That being said, most of the studies that we've done so far have only looked at really intermediate outcomes, what it does to that average blood sugar level, what it does to your use of medications, that sort of thing. And we're still waiting for data to say that, hey, kind of like some of our gold standard, sort of more holistic therapies, what does this do to those outcomes that really make a big difference in our lives? Your risk of death, your risk of some of those downstream consequences, heart attacks, strokes, loss of limbs, retinal problems, that sort of thing. So it's not to say that keto diets can't potentially do that, but the jury is still out as we wait for more evidence on some of those long-term effects, even while acknowledging that some of the intermediate outcomes that we look at do look pretty good. I'll also say that keto diets, when they study it, also tend to be a little bit difficult to keep. Any diet can be difficult to keep, no doubt, but that's the only other sort of question mark there is how sustainable can keto diets be over the long term. Again, thinking about long-term complications happening over years. All right. Do be careful about when somebody says if you're worried about diabetes and if somebody says sugar-free, do be a little bit cautious. Take it with a grain of salt. These are sugar-free York peppermint patties, and literally, it says sugar-free right here. But then you go down and you look at the dietary nutrition facts, and you actually end up with 25 grams of carbohydrates. So just because it doesn't have sugars doesn't mean that it doesn't have carbohydrates, including sugar alcohol, which ultimately can do similar things to blood sugar levels. With diet, the other really crucial pillar to lifestyle therapy for diabetes is exercise. And if we can think about diet as being your ability to limit how quickly the sugar rises in your body, exercise is the opportunity to more quickly pull that sugar that's in your blood vessels out of the system and to reduce the damage that it can do there. The exercise guidelines for diabetes look really similar to ones for heart disease and are just probably good principle for any of us as we age. But we try to recommend at least 150 minutes. That's 30 minutes a day, 5 days a week. We don't want to necessarily do it all at one time. We want it to be, as I'll make the case in a minute, we want it to be spread out over multiple days, so you're not just getting one push. The more frequent, the better. We also want to get some resistance training. That, again, thinking about working your muscles also really helps suck out that extra blood sugar out of people's veins. It made, from a general good principle standpoint, working on flexibility. We've got yoga, tai chi, as you've probably heard Tasha and I talk about in other talks. Lots of benefits to risk of falls, risk of broken bones. And the good news is that exercise in older adults may be even more helpful than it is in younger adults. That it makes more of a difference as we age versus when. Just again, I want you to take away from this the thought that all this should be holistic. That if you're approaching lifestyle, think about it not just in terms of I got to get 30 minutes of exercise 5 days a week, but rather think about it as, hey, the more movement I get during the day, the better. So that means trying not to sit in one place for more than 30 seconds. If you can intensify 30 seconds. Yes, yeah. Thank you. 30 minutes a day. Uh, don't think about just getting 30 minutes a day. George, no ideas. But if I can keep moving, if I can avoid being sedentary, if I can intensify the exercise a little bit, that even if we can add 500 steps a day, that intensification seems to have proportional increase in heart disease reduction of folks with diabetes. But if you can go hard a couple times a week and really get the sweat going, if you can increase your strengthening, which is, like I said, is going to help you suck out more blood sugar out of the bloodstream. And then if you could think about making sure you're getting enough sleep. That we've got some evidence to say that if you have less than 7 hours of sleep, that your blood glucose control, your blood sugar control is a little bit worse. If you're a night owl like me, unfortunately, there's also some evidence to say that night owls tend to have a little worse sugar control versus early morning risers. So if you can shift your schedule, great. But I know from experience that can be challenging. Good. All right. So hopefully that gives you a little bit of a sense that lifestyle differences can make a difference. But often we also have to think about using medications. And for that, I'm going to hand it over to my much smarter pharmacist friend, Tasha.
All right. So first, as I start talking through each of these medications, I want to go back to what Will was saying at the beginning about what diabetes is. And this probably is not completely unfamiliar to any of you. Sometimes we use that analogy of blocks and keys. Will talked about the sugar being in the bloodstream, and you have to have a little bit of sugar in your bloodstream. But for the most part, that's not where it works. In order for us to have energy in our tissues and our muscles to be able to move around and do things and have brain power, the sugar needs to get out of the blood and it needs to get into the tissues. And so if we think about little doors on those blood vessels that allow the sugar to exit through them into the tissues where they can be taken up and used as the building blocks of energy, insulin is like the key that unlocks those doors. So in someone who does not have diabetes, the way that normally works is you eat a meal and your blood sugar starts to rise and your pancreas starts to produce all of these keys in the form of insulin that's going along and unlocking all of these doors to allow the sugar to exit the bloodstream and go where it needs to go, right? And he talked about the fact that in some instances, the problem is that you don't have enough keys. Certainly that's the case in type 1 diabetes. Your pancreas can't make the keys. And many times when you've had type 2 diabetes for a very long time, your pancreas starts to wind down that production as well, and you end up in a place where you're not making as many keys. Other times it's an issue with what we call insulin resistance. It's like the locks get jammed, right? The insulin is there, it just doesn't work as well because something is different about the lock or the door where the door is not opening as easily as it should. So I just wanted to kind of lay that groundwork so that we can talk about how each of these medications builds into that picture of what's going on with diabetes. So metformin was like our gold standard for years and years, and it still is to a certain extent. This picture up here, I've got little pictures on all these slides that show you where these medicines work. That's a liver.
So our livers also play a role in this because livers actually make sugar as well. Part of the sugar that ends up in your bloodstream comes from the food that you eat, but part of it also comes from the sugar factory in your liver. So metformin does a couple of things. It works by increasing insulin sensitivity so that your keys work better on the doors. But it also, and this is probably its primary effect, it decreases that glucose manufacturing in the liver. So it works pretty well. It lowers A1C usually by 1 or 2%, but even more to the point, and I've highlighted for each of these medications in yellow over here in these like pluses and minuses boxes where we see other benefits outside of just lowering your blood sugar. Because at the end of the day, it doesn't even really matter what your blood sugar meter or what that printout from the lab says your A1C is. It matters whether you're having kidney problems. It matters whether you're having heart attacks. And so we do know that metformin seems to protect people from having heart and kidney problems. We also really like it because it carries a really low risk for low blood sugar. And again, that comes from the fact that it's not doing anything to interfere with your body's normal mechanism of responding to carbohydrates when you eat. It's primarily working by just shutting down that new liver production or new glucose production in the liver. And it's been around forever, so it's really cheap. Con side, of course, no medication is without side effects. The ones that we see most often with metformin are things like diarrhea or nausea, which is the reason that we tend to start this one at a low dose and carefully and slowly escalate the dose. And still, ultimately, some people really just can't handle it, but most people can if we go about it in the right way. It's also associated to some extent with deficiency in vitamin B12. So sometimes, especially if you start to have some nerve pain or neuropathy, that can result from diabetes itself, regardless of the medications that you take. But if you're taking metformin, we might check a vitamin B12 level and say, all right, I still want you to take metformin, but let's supplement some vitamin B12. SGLT2 inhibitors. When I moved to Asheville to do my residency, these had not been invented yet, so I've been having to play catch up. These work in the kidneys. That's what these things are. And there are 3 medications so far in this class, which you probably know by the brand names that you see advertised on television: Invokana, Jardiance, and Farxiga. Farxiga or dapagliflozin has gone generic, but it's not cheap yet because it just went generic. So it'll take 6 months or more for that price to start to come down. But they work totally differently from any other medication that came before it. They have nothing to do with insulin or the keys that unlock those doors. All they help you do is pee out extra sugar. And they work pretty well. I mean, they can lower your A1C most of a percentage point. But more to the point, again, I don't care quite so much about that. They have some really cool benefits for your heart and your kidneys, and that is why we're using these more and more. They also carry a pretty low risk of low blood sugars. It can cause a little bit of mild weight loss because this is a medication that is actually helping you pee out calories in the form of sugar. Literally, that's what it's doing. And it could actually lower your blood pressure through a little bit of a diuretic effect. But of course, too much of a good thing, right? On the con side, we could run into dehydration. And because you have more sugar in your urinary stream, that is the favorite food of some bugs like yeast or fungus. And so we can see sort of an overgrowth that might manifest as infections in the urinary stream, urinary incontinence potentially. And again, they're newer, so they're more pricey right now. Stop me at any time if you have questions about these. And then the GLP-1s, which are the talk of the town these days. And they work a lot of different places, but primarily in the gastrointestinal tract. So this is a stomach. There are more medications than just these 4 in this class, but these are the ones that we're hearing a lot more about because they, more than the others in this class, again, have these heart and kidney benefits. Ozempic and Mounjaro and Trulicity, which are given once a week. Victoza, which is given once a day. Now down here, some people don't mind, but for those who do not enjoy injections, these are injections similar to insulin, except again given as infrequently as once a week. Um, they work in a lot of different ways that are pretty neat. They actually increase insulin production, but only in response to food. So the nice thing, the reason that they have a low risk of hypoglycemia is that they will only cause your pancreas to make more keys, more insulin, if you've eaten a meal, which helps us because if we get too much insulin dumping into the bloodstream when we haven't eaten a high carbohydrate meal, it goes too far. We overcorrect and we end up with a low blood sugar. So it's really kind of nice the way that this works by increasing carbohydrate sensitive insulin production. It can also slow down the emptying of your stomach. Will was talking about these carbohydrates, how complex whole grains are broken down a lot more slowly so that the carbohydrates don't all hit your bloodstream at one time. That's different than something like candy, something with a lot of refined sugar in it that's all going to dump in there at once. So regardless of what you eat, these medicines slow down the emptying of your stomach so that that sugar is trickling into the bloodstream much more slowly and in a way that your body can manage better. And they also send these signals, I'm full, to your brain, which is a reason that they can cause really significant weight loss. This tirzepatide or Mounjaro is actually a dual mechanism. It targets not just glucagon-like peptide, but GIP. I think I figured out what that stands for. I can't remember what it is because that's a novel one in this class. It's a GIP-GLP, and it can cause upwards of 50 pounds of weight loss if you're using it in that setting. So we don't recommend that for everyone. Thank you, gastro-inhibitory peptide. Thank you. And again, they work pretty well for A1C lowering. Now, on the side effect side, I already mentioned the fact that they're injections. They are also newer agents, so they're more expensive, and they can have a lot of these GI side effects too. So similar to metformin, we start people on lower doses that we don't expect to cause a whole lot of A1C lowering or even a whole lot of weight loss, really just to help your body get used to it, and then we slowly increase the dose. Pioglitazone or Actos is one that's been around for a while, but you don't hear about quite so much anymore. This is muscle fibers. So of all of our medications, these medications like pioglitazone are probably the most potent insulin sensitizers that we have. They help unclog those blocks so that the insulin that your body is making on its own can work better. And again, pretty good A1C reduction. Now, these have not been studied as extensively as some of the newer medications, but there are some studies to support the notion that they may potentially reduce the risk of heart disease or reduce the risk of a stroke if you've already had one. Very low risk for low blood sugars. It's been around a while, so it's very inexpensive. It can, especially at higher doses, cause more swelling in the extremities, like the ankles. It can cause some weight gain, although interestingly, whatever weight gain that you incur from taking pioglitazone does not contribute to additional cardiovascular risk, because instead of picking it up in the visceral compartment that packs around your vital organs, it's more in the subcutaneous compartment. It's just an extra layer under the skin that doesn't really add a whole lot in terms of risk. Rarely we can see other side effects like fractures, especially if you're a woman who's been through menopause. And we do have to be careful using this in people who have chronic heart failure. Other medications that we don't use as much anymore are the DPP-4 inhibitors, dipeptidylpeptidase. I'm pretty sure that's what that is. And these inhibit the breakdown of endogenous GLP-1. So GLP-1 is a hormone that your body makes naturally on its own, but it has a very short half-life, meaning it's made and then it decays very quickly. So DPP-4 inhibitors block the enzyme that breaks that endogenous GLP-1 down and helps it live longer so that it can have a similar effect to the GLP-1s that we give as weekly injections. But these are daily pills, and they're not quite as potent, so they may only have about a 0.5% A1C lowering. There are a number of them. Januvia is probably the one that we see used most often. And so how they work is essentially the same as how the GLP-1s work, except they're not as potent added. Good news though, low risk of low blood sugar. They're really very well tolerated. They're safe to use even if you have kidneys that don't work as well as they once did. But unfortunately, they've fallen a little bit more out of favor because they don't have these additional proven benefits like the newer medicines do. And then the last oral medication I'm going to talk about, I think, before we get to insulin, of course, are the secretagogues. These are medications that G drugs, glipizide, glimepiride, glyburide, and they work in the pancreas, causing it to secrete more insulin, more keys to unlock those blood vessels and let sugar out. Now, the problem is that these carry very high risk for hypoglycemia because unlike the GLP-1 drugs that only cause you to produce more insulin after you've eaten a meal, if you have a day where you've eaten a little bit more lightly or maybe you're sick and not keeping food down, you run a pretty high risk of running too low of a blood sugar if you're taking one of these medicines because if you've got it on board, it's bringing on your pancreas, causing it to produce insulin, whether you have glucose there or not. And they do not have the additional proven benefits either. So for this reason, these medicines have really fallen out of favor and we try to avoid them when possible. And then, of course, insulin. There are lots of these. There are the longer acting ones. There are also the rapid acting ones that some people will take with meals. They can be pretty inexpensive depending on your insurance. Although, as a side rant, part of the Inflation Reduction Act was supposed to be that people on Medicare would not pay any more than $35 a month in insulin products, and it turns out that that is not the case right now. Evidently, the people who are involved with implementing that are tied up in litigation at the moment. So that's apparently not happening for the folks that we have at our community pharmacy at MAHEC. It's not going through as consistently as we would hope. It's easier to fine-tune your treatment when you're taking insulin, and there's really no ceiling effect. We can get your blood sugar down as low as we need it to go with insulin. The problem is that depending on a lot of other factors that impact your blood glucose, it can be really difficult to predict, and that's why sometimes, again, we run into this risk of low blood sugar. So I'm going to take you back to when we first started talking about what should my goal be. And I will say that those graphs were specific to people with type 2 diabetes. But remember, I showed you that J-shaped curve where there was a survival benefit to sticking to the middle range of A1Cs. And particularly if you're on a regimen that includes insulin, we worry more about some of the consequences, the adverse consequences of not only having a blood sugar that's too high, but one that's too low. And most of these are injections, although we do now have Afrezza, which is the inhaled insulin. So I thought I'd be remiss if we didn't talk a little bit about how we manage hypoglycemia when it happens. But before we get there, are there questions about any of the medications? Mindful that we're running a little short on time, but don't have too much more to cover. So if you don't mind to disclose, has anyone ever experienced a low blood sugar? And were you able to catch it when it happened? Yeah. So the things that we do, and sometimes you can recognize when it's happening, and other times, like Will was suggesting earlier, it's really difficult to figure out that that's exactly what's going on. But we try to get, in this instance, a serving, which we call, 15 or 20 grams of fast acting carbohydrates. We don't want to wait for that whole grain toast to hit your blood sugar in 30 minutes to an hour. We need something that will act fast. There are lots of options. That could be some orange juice. It could be a half a can of a regular soda. Don't reach for Diet Coke. It's not going to increase your blood sugar. Um, Honey, and certainly there are those glucose tablets. Normally you would chew 3 or 4 of those, depending on the brand. And then you wait 15 minutes, check your blood sugar again, and then if it's still low, you kind of go through the same thing. Now, in emergency cases, if you are someone who is caring for a person who has diabetes and they're unable to take any of these sources of sugar by mouth, that's when we use glucagon. And all of these things are different products that are on the market now. This orange case was the old form of glucagon that requires you to squirt the liquid into the vial and then shake it up and reconstitute this tablet as a suspension or a solution and then inject it into the muscle. And now there are a couple more of these, this Baqsimi and Gvoke, that are a lot easier to give so that the person who's really worried about you and flustered about what's going on doesn't also have to worry about being in chemistry lab and shaking up a medicine. And then lastly, when we're talking about medications in the setting of diabetes, other things are really important too, because we talked about the whole reason we embark on this journey of treating and managing diabetes is to manage those long-term downstream consequences of things like heart attacks and kidney disease and strokes. And so equally, if not in some cases even more important than managing blood sugars, we have to think about being adherent with our medications for high blood pressure and high cholesterol, especially if you've had a history of one of these events. Okay. Very last thing, we wanted to mention a few things related to monitoring blood sugars if you have to, and if so, how's the best way to do that? So I'll pass it off once more to Will.
All right, guys, last little bit. So I think one of the most common questions I get if I've made a new diagnosis of diabetes, hey doc, how often should I check my blood sugars? And the answer is it really depends. But for the most folks who do not require insulin to control their diabetes, the answer is actually probably rarely, if ever. I tend to not recommend folks routinely check their blood sugars if they've just got type 2 diabetes that does not require insulin. The studies have shown that for all the monitoring we do, that doesn't actually necessarily translate into better outcomes. It doesn't translate into better control. And for those of you that have had to prick their fingers, they know that doing that day after day, multiple times a day, can really impair quality of life. And so just know that for many of our studies, there's the suggestion that intensive monitoring without insulin probably doesn't make a big difference. Now that definitely changes if as you've heard us say several times, insulin really increases your risk of low blood sugar, and so more intensive monitoring is often really important. There are some new tools that really help us with this. So I just wanted to highlight that there are these continual glucose monitors that have hit the market and are becoming more and more accessible to people. Medicare, particularly, is becoming more willing to pay for these. And these are devices where you have a little sensor that rests in your skin for up to 2 weeks, and you have a little sensor that works by Bluetooth. And if you scan it, it'll automatically read what that sensor is getting. There can be little variations. It's measuring not necessarily your blood glucose, but the glucose in what we call the interstitial fluid. But it's a pretty good comparison, and can be really helpful in terms of reducing the burden of folks that are on insulin. And it can also provide interesting data as you're trying to treat diabetes about when you're higher, when you're lower, and allow you and your clinician to really individualize and tailor the medication regimen to help you with this. Um, it also has, when somebody has a continual glucose monitor, we think about the way that we interpret the data as what's ideal a little bit differently. You can think about that A1C that we keep coming back to. But the glucose monitor actually allows you to say how long you are in sort of an ideal range. And so the new guidelines have actually started saying, okay, instead of A1C, you can think about, if you have a monitor, how often are you in this ideal range? Good. I will finish with that. I hope, if nothing else, you guys have heard me say, I heard both of us say, the paradigms in diabetes are changing. So we're not as strict as we once were. We're thinking a lot more about the causes of death in diabetes, being heart disease and stroke, and not thinking just about what sugar levels are, but thinking about how can any therapy, whether it's lifestyle therapies or if it's our medication therapies, how they can influence our risk of heart attack, stroke, and death, not just what they do for our blood sugars. Um, I hope for all of the whole spectrum out there of you guys in your engagement with diabetes, that would provide a little bit of information. Anybody have any questions? That's a great question. And so typically the standard answer is going to be 3 months, every 3 months. That being said, if somebody is, I think you got to be a little bit reasonable too. So in my own practice, if somebody's been rock steady for a long period of time, they've been well controlled, then I think you can sometimes back off reasonably to every 6 months unless somebody's having symptoms or new concerns come up.
Yeah, I was reading an article from Harvard Medical. One of the doctors was talking about metformin, and they said it had been used for 40 years. And he said that some people at Harvard, other doctors, had thought that it was so wasn't just about diabetes and stuff, that the people who had taken it for 30, 40 years, or whatever, long periods, that they had like 10% less heart attacks, strokes, and he was saying there's some talk between Cleveland Clinic, Johns Hopkins, and all these places, and Harvard Medical, to declaring it a miracle drug and prescribing it for everybody. You heard anything on that?
Yeah, and I will say that going back to that pre-diabetic category, there's a lot of debate about, and Tasha probably can speak more intelligently than I can, but there is debate about, do we, because it has these ancillary benefits in folks with diabetes, should we go ahead and put folks with pre-diabetes on metformin? And I think the preponderance of evidence at this point, there's still debate that maybe not. Because again, all these, even metformin, even though it has those great qualities that it reduces your risk of death with diabetes, it reduces your risk of heart disease, it still has downsides, right? Just like any medicine, and a lot of folks don't tolerate the GI side effects, that sort of thing. So it may not be for everybody at this point, but no doubt, I think you hit on the key point that Dr. Woodall was making too, that when we're thinking about medicines, it's really, we're trying to get away from just thinking about what does it do for our blood sugar. We're thinking about what does it do for our risk of heart attack and stroke? What does it do for our risk of dying? And metformin, the GLP-1s, the SGLT2s, all those are really hot right now because of those. They do those core things, not just reduce your blood sugar, but they really seem to reduce your risk of a lot of these sort of end-stage diseases that really affect the life and death of folks with diabetes.
That has that effect? It sounds like your overall health. You might have a little stomach upset, but if your overall health is much better, do they know how it affects all your heart and all that stuff?
I don't think that is well understood, and I think the data that you're talking about is now starting to emerge with some of these GLP-1 agents and the SGLT2 inhibitors as well. And so it'll be interesting 20, 30 years from now to see if those have completely overshadowed metformin in terms of that additional benefit. But I think there has been an interesting shift in focus from the A1C that in some instances is it kind of a red herring? You know, we're so fixated on what the A1C is, but is it more important just to have people on a combination of medications that can lower their risk for, um, you know, the bad consequences that we're trying to prevent by getting the A1C to a certain level? So, yeah, I think metformin, similar to the GLP-1s and some of these other newer agents, does have benefits that go far beyond its ability to lower blood sugars.
That these people were living longer and being healthier and coming closer to just, you get to a certain age, 80, 90, whatever it is, you just drop over dead. You don't have diabetes, you don't have they don't have heart attacks.
Yeah,
And so
good deal.
that Harvard doctor, I think they're doing research on it. They're
Yeah,
new.
sure.
If, as you have said, 27% of the adult population is likely has undiagnosed diabetes, have you had any discussions with Deerfield about doing A1C testing for our population?
It's another good question. It gets back to some high level philosophical questions, not philosophical, but just risk benefit questions of the role of screening. And keep in mind that it was about 20% of diagnosed, and then another 5% to get to that, or 5.5% to get to that 26, almost 27 level. So it, as with any screening, there are pros and cons. The pros are that you can catch diabetes earlier, but the cons are that you want to know whether it actually makes a difference. And so far, screening for diabetes, other than doing a fasting blood glucose, tends to seem to not reduce your average person's risk of death, heart attack, stroke, all those sort of things that we care about. Anytime you do testing, you can incur the risk of false positives. So right now, the balance hasn't really swung towards, and especially in a population like Deerfield, and this is coming from the sort of global U.S. Preventive Task Force recommendations, looking at that whole population of Americans. And I think you can make the case that Deerfield, because our prevalence of diabetes is already a lot lower than our general population, that probably screening in this population makes even less sense.
C-peptide, sorry about that. C-peptide is kind of like a surrogate to see how much insulin someone is producing because it's co-secreted along with insulin. And sometimes we check that to determine what's really going on here. Is this kind of a type 2 insulin resistance problem, or is it more of a type 1 picture? So I'm not aware of any role for C-peptide as it relates to screening, but it has a role in determining how to go forward with therapy if someone shows up with outrageously high blood sugars, needing to go to the hospital, some of these other things that might tip us off that this isn't a normal, we've come to a point where we've progressed to type 2 diabetes to try to determine what the underlying cause might be.
That's exactly what if somebody is new with diabetes, or all of a sudden doing the same things they already have, has really worsened the control. I think that maybe it's insulin production problem all of a sudden. That's what I'm checking.
Long-term use of metformin, at what point, if you have an increasing frequency of diarrhea, do you consider using a different drug?
That really kind of depends on the individual. I think, we have different things that we can try if someone is suffering diarrhea where we can back off to the starting dose and take it much more slowly, try an extended release formulation, try taking it with food. We try all of these various things, and sometimes even people who have had really bad diarrhea previously on metformin do okay once we re-challenge with it in the right way and do it much more cautiously. But if it's still an issue that's impacting quality of life. I think we've got plenty of other good options on the table at this point where sometimes we just have to cross it off the list.
Okay, y'all, we are just at 4:10, so I'm going to end the questions there. If you can hang around for just one more minute, we're going to have Jim Havard come up and say a word.
Thanks, everybody.
Thank you. As I look around the room, I see a lot of people that are already aware that we have here at Deerfield a resident-supported diabetes support group. And I wanted to remind everybody it's a small group, but we have all types covered. We have people there that are type 1, type 2, pre-diabetic, people that are interested because their partner's diabetic or they have some other reason for being interested. We have this week, Wednesday of this week, our next meeting, which is our March meeting. It's on Wednesday the 12th at 1 o'clock in the Riverwalk Conference Room. Now, Ellen, our dietitian, Ellen Birch, is also a member. And a little question to ask the docs if I can. I don't believe there is a single pill that you can take that will cure diabetes. However, with good food control and lifestyle changes, you can control it. Ellen Birch, our dietitian, is our best source of information for both of these. Not saying that you're not good sources, but she's terrific.
My 2 cents is that I work with Ellen closely, and I could not agree more. And she truly is really wonderful. And not just Ellen, but nutritionists of all stripes are just really wonderful resources in this case.
Couple other things real quickly. I'm distributing weekly a distribution, the menu from the bistro where I've gone in and marked carbs by dish. If you'd like to get on that distribution list, see me, give me your email, and I'll make sure you get that. We're also posting the notes of the meetings. They're posted on the dining committee as also the health and wellness committee. We're posting research papers as we run across them, and probably we'll put up shortly some WebMD articles, some of which are kind of interesting. 10 surprising sources of carbs. These 10 fruits are lower in carbs. And which foods have more sugar? You might be surprised. So in any event, I wanted to make sure that everybody's invited to the Wednesday meeting, and to thank the docs for coming. That was really very helpful. Thank you all.
Thank you all so much for coming, and let's have one more round of applause for Doctors Woodall and Mclean. Have a great day, everyone.